Hey everybody, before we get started, just wanted to let you guys know that this episode is another one of our ACPE accredited continuing education episodes. So once again, we have partnered with Free CE by PharmCon to basically provide listeners the opportunity to claim 1 hour of home study continuing education credit after listening to this episode. So there will be a link in the show notes. Make sure you follow that and use the password glucose in all caps, and that will allow you to take the actual exam. Once you pass that, you'll be able to receive your credit. You do have to be a member of freece.com in order to actually get the continuing education credit. But if you are not a member, if you use the code CORCON, so CORCONRX, all one word, capital letters, and that'll be in the show notes as well. And up through now until June 30th, 2021, then you'll get 15% off the annual fee, and you'll be able to have access to not only our podcast episodes that are accredited, but also access to all their monographs, live lectures, and everything else that they have on their website. So make sure you check that out, and I hope you enjoy the episode. Thanks. What's going on, everybody? Welcome to episode 146 of the podcast. Slowly approaching 150, Cole.
Yeah.
Getting there.
That's halfway to 300.
It is literally exactly halfway to 300, so that's good news.
It is.
So we're going to have to think of something cool for episode 200.
Oh, yeah. We had Dr. Wirt for 100.
We did. That was good.
What about our bicentennial?
Whew, I don't know. There's not really a way to beat Dr. Wirt, so
maybe we'll just have him come
back.
We'll have him
come back.
Just do the same one. We don't even have to have him come back. We'll just release the same one
Re-release
again.
it? Re-release. Yeah, that is a good idea. Now we're thinking. So today we are, like I said in the intro, we are going to be going through the diabetes injectable medications, and this is going to count for continuing education. So we're excited about this. Hopefully, I know you guys are like, oh my gosh, they're doing diabetes again. But we're going to concentrate solely on injectable medications.
Yeah, so we're doing what we always say we're going to do when we're going to focus on a specific thing inside of a disease state.
And then we never end up doing that because we get sidetracked. But we're going to stay on task today.
Yes.
We're going to try our absolute best to do that anyway, and go through all the different injectable medications, the insulins, the GLP-1s.
There's some new stuff. There
is some good stuff. And it's kind of another way to help kind of excel your learning through this podcast. I wanted to make sure I mention our sponsor for this episode, which is Pearls. So Pearls is a drug reference for the next generation of healthcare providers, and it's something that allows you to learn quickly about commonly prescribed medications. It can be used as a quick reference, counseling points, clinical pearls, hence the name, Pearls, get it, comparison charts, and more. You can find it at pearls.com, and that's PYRLS.com. And then I also encourage you to download the mobile app for iOS and Android for limited time. Actually, we don't even know if it's limited. It's probably going to be longer, to be honest. Core Consult RX listeners can sign up for free and download a 10-page diabetes pharmacotherapy chart bundle that is yours to keep. You just sign up with your email, and Pearls will send you the 10-page document to your email, and then you can decide from there if you want to continue, with Pearls, on the actual app and whatnot. So it's great. Cole and I have both been using it lately, and we're going to actually use it through the episode it is to kind of reference some things. So if nothing else, check it out and get your 10-page diabetes pharmacotherapy chart for free. So thank you so much to Pearls for supporting the episode. So there you go.
It looks great. It's much better than anything I could have put together.
Oh my gosh. Sure. Yeah. I realized how terrible I was at like anything artistic when
the colors and everything. I was like, this is so good.
It's great.
Mine would have been black and white.
Mine would have definitely. That's why we're not programmers and artists.
Exactly.
All right, man. So where do you want to go as far as the actual content?
So injectables with diabetes. So specifically we're going to focus on type 2, but of course, insulin, which we'll talk about, applies to type 1, and we'll reference some type 1 stuff as well. But it falls into two camps. There's insulin, and then there's GLP-1. GLP-1 agonists, those two. So you want to start with the GLP-1s, which are more specific to type 2, and then we'll talk about insulin, which of course is involved with type 1 as well.
And I think that's a big kind of switch from the way we used to think about things. I know, like when I was in school, I used to think if a patient's A1C was at baseline in the double digits, if they were 10 or 11, insulin was just the automatic option to start with.
Right.
However, most patients will do very well with a GLP-1 receptor agonist if we start that even prior to insulin, basal insulin and whatnot. And in fact, for me, especially, with my type 2 patients, it's pretty much my go-to second line option after metformin. Even if their A1C doesn't need a ton of reducing, just because we have such good options in that class of medications now.
And we'll talk about it a little bit when we go through them. But as far as ADA recommendations go, they say if you are very high risk for ASCVD or you have ASCVD, they recommend adding one of the cardiovascularly beneficial GLP-1s, regardless of metformin status, A1C status, and obviously, I guess if there's definitely a point where you probably wouldn't want to use it, but they recommend using it just for the cardiovascular benefit itself.
The important part about GLP-1s, though, is they are not all created equal, and so this is just something that we're basing this off completely, so the data that's available, and we'll quote the studies and whatnot, but they do have some differences between them other than just the dosing regimens and whatnot, but they actually have different data, different A1c lowering ability, different weight loss. So it's something that's important to kind of know the differences between them, because it can really help you decide which route you're going to go when you're picking one of these.
Right. And, we tend to take strong stances on certain things that we like if the data supports it, right? But a good example of how we can evolve with data just like anybody else is when we first started the podcast, we might have said Victoza all the way. And then, Ozempic was coming out. We're like, Ozempic's going to be the next big one. And then we got data for Trulicity and that's like Trulicity. So, we might feel strongly about one having stronger data than another, but data's always evolving and new things can come out. And so that's why you want to roll with the punches and stay up to date on whatever we think is the best.
Yes.
But that is to say that
we think is the best.
There are some good options that can, are very reasonable, but then there's also some bad options where the data just wasn't all that nearly as good as the others, and so we're probably going to stay away from those.
Yeah. So I guess just to kind of start out, what is a GLP-1 doing? And if you've listened to our older podcasts or our case episodes, where we've kind of walked through a patient case regimen, you'll probably, if this is a review for you probably, but that's okay, because there's a lot of different mechanisms at play when it comes to GLP-1 receptor agonists. Primarily, we think about a kind of stimulated insulin response to a patient consuming carbohydrates. So the difference between like exogenous insulin, when that's injected, the patient obviously then immediately has their blood sugar lowered. And when you're talking about like prandial insulin, if that's not timed correctly with meals or something like that, they could really have a risk of a hypoglycemic event. With GLP-1s, they really only start sort of kicking in, for lack of a better word, when the person actually consumes carbohydrates. And then once it brings you down to a certain level, that's kind of where it keeps you, and it's not going to bring you lower. So the risk of hypoglycemia is very low compared to something like insulin or some of our oral agents like sulfonylureas.
Which we can't overstate the importance of that, because hypoglycemia is a huge concern, especially with the older glucose lowering agents.
Absolutely. So we're going to get that the beta cell insulin release whenever the patient consumes carbohydrates. And then the other piece of that is we're going to also inhibit glucagon secretion. So when we inhibit glucagon secretion, if you think about, insulin and glucagon are what keep each other in balance. So if the insulin levels start to go up, the natural response of the body is then to increase glucagon to balance that insulin back out again. Well, when glucagon is there, you're going to have processes in place like gluconeogenesis, glycogenolysis, things like that can increase your glucose content in the blood. And so we want to suppress that glucagon so insulin can be allowed to hang around longer and do its thing. So you're getting that glucagon suppression and the insulin release at the same time. And just to kind of throw this in here, if you ever see someone who has type 1 diabetes that is on a GLP-1 in addition to their insulin regimen, if you're confused by that, because obviously in a type 1, you're not going to get the insulin release from the beta cells because those have been destroyed at that point. But the glucagon suppression is really where the benefit lies with the GLP-1s in a type 1 diabetic. Now, these aren't approved for type 1s, so it's off-label, but the glucagon suppression allows usually the patient to inject less exogenous insulin over time, helps with the weight gain over time that's seen with just using insulin by itself. And so I've seen a few times now in practice where patients that are type 1s can get some real benefit from having a GLP-1 added on as like adjunctive therapy to their insulin regimen.
Right.
So if you ever see that, that's what they're going for. They're trying to suppress glucagon. They're not really worried about the insulin release piece of it.
Similar thought process to metformin with insulin, where we have some data saying that you can decrease the insulin requirements when used with metformin in type 2s. And that just goes to say that insulin is great and, fantastic as far as when it came out and being able to treat type 1 diabetics, and then, of course, being able to treat type 2 diabetics well. But it has some undesirable effects, which we'll talk about. So it's kind of pretty much determined now that GLP-1s are preferred if possible, and decreasing the insulin burden as much as possible to a safe extent is a positive thing.
Now, the other kind of piece of the puzzle with GLP-1s is their ability to sort of deal with gastric motility. So you're going to decrease that gastric emptying after a meal. Patients often have their decrease in their appetite. They often have increases in satiety. So that's going about by a couple different ways. Primarily, it's like I said, decreasing gastric motility helps with increasing like acid secretion, as well as decreasing that gastric emptying. But there's also GLP-1 receptors in the hypothalamus as well that affect appetite. So they actually decrease those pro-opioid melanocortin neurons, or POMC neurons. They decrease the firing of that, which then leads to that increase in satiety after a meal and decreases appetite. So it basically those four main mechanisms, and there's others as well, including some cardioprotective properties as well, which we're going to talk about. But the GLP-1s are coming at it from so many different angles that you're really getting a solid benefit from.
Right. So all that results in decreased glucose levels, lowered A1c without hypoglycemia, weight loss, negatives being frequent GI upset, specifically nausea, which is something you definitely want to counsel patients about early on. And then there's the concern for like thyroid cancers, which they've seen in mice, but I don't think they really have had any documented cases in humans, but it's still something that they throw in there. Also, which we're about to talk about, the data for cardiovascular events, and the mechanism behind that is a little more unclear. Maybe it has to do with, glucose control. Maybe it has to do with weight loss. They also think it causes some endothelial vasodilation, which could decrease inflammation and over time, prevent cardiac events. But in some of the studies, they saw decreased cardiac events in a very short amount of time, where when they've looked at it, secondary prevention from just a glucose control perspective, you wouldn't have seen a decrease in that short amount of time. So there's something else going on other than just the glucose control, and maybe even more than just the weight loss. And probably also why it's not necessarily a class effect where it's not only not causing cardiovascular harm, but we're actually seeing benefit.
So, like we said earlier, not all of these are created equal. So just to give you a couple differences just in the dosing of these, for example, exenatide or Byetta, which is what the original GLP-1 receptor agonist, is a twice daily GLP-1. Then we have Victoza.
We've come so far since a twice daily GLP-1, haven't we?
For sure. And then we have liraglutide, which is Victoza. We have lixisenatide, which is Adlixin. Those are both once daily. And then our once weekly options, we have exenatide ER or Bydureon. We have dulaglutide or Trulicity, and we have semaglutide Ozempic. We used to have albiglutide, which was Tanzium, but that was removed off the market. Sorry for those guys.
Good old Tanzium. The one that you had to set in a cup upside down or something for 30 minutes?
Yeah, you sure did. It was very annoying to have to reconstitute it. But what are you going to do? Now, let's talk about just A1c lowering for a second. So when for when it was just Byetta and Victoza, those were the two main GLP-1s, obviously, because that's all that was on the market. Then Victoza was clearly the market leader. It had more attractive dosing regimen as far as once daily versus twice, and it also had better A1c lowering when it was compared to exenatide. Now, there was a study called Duration 6, which was exenatide ER versus Victoza head-to-head, and
which was once daily, right? Exenatide ER?
Exenatide ER was the once weekly by Durnion.
Oh, once weekly, I'm sorry, yeah.
And they were trying to show non-inferiority and superiority with exenatide ER compared to Victoza for A1c lowering. Unfortunately, did not meet the criteria for either one, so basically paid a lot of money to show that Victoza was a little bit better.
That's a dangerous thing to put class medications head to head, and that's why you don't see it very often. It's a risky thing for the drug companies to do.
It is, but I do respect that.
Oh, I'm all for it. I think it's better for medicine.
Good on them for
I wish they would do
doing
it more,
the right thing.
Wish they would do it more often, kind of like the VA's doing a big, which is not a drug company, but VA's doing a big study with hydrochlorothiazide versus chlorthalidone right now. But yeah, I wish drug companies, especially when they're branded, would do this more often.
Yeah. And then same with Tanzium. Tanzium was inferior to Victoza for A1c lowering, which is one of the reasons why it was removed. And then the Trulicity came along with the Award 6 trial and showed that it was non-inferior to Victoza for A1c lowering specifically. Victoza still had better weight loss associated with it and whatnot, but the Trulicity was kind of like the next, generation that was also efficacious and hit that A1c lowering ability like Victoza did, but only once weekly.
Yeah.
And then Ozempic came along, and that one has been compared directly to Trulicity. And Ozempic is obviously owned by the same company that has Victoza, so they didn't do a head-to-head study with each other, but they did compare it to Trulicity head-to-head with the Sustain 7 trial, and semaglutide was superior for lowering A1c. I think if I remember correctly, it was 1.1 A1c reduction for Trulicity and 1.4 with Ozempic. So clinically maybe not as impressive, but definitely still better considering it was a head-to-head trial. And the weight loss, which we'll talk about in a little bit, but the weight loss was definitely better with semaglutide. And now that it has the new 2.4 milligram version that's been just recently approved for weight loss, we see some huge weight loss ability with semaglutide specifically. I don't know what it is about that particular GLP-1, but it'll make you lose some weight.
Yeah, just as long as we're on that, I believe it's pronounced Wegovy, which I think is an interesting name. But in the trials, that you had to have a BMI over 30 or BMI over 25 with other risk factors like diabetes. And the patients, about half of them lost 15% of their total body weight, and about a third of them lost 20% of their total body weight with that 2.4 milligram dose of semaglutide. It's pretty intense.
Yep.
Yeah. And then now we have oral, right? Rybelsus.
Rybelsus. We can't talk about that, Cole, because it's oral. We're only doing injectables.
Oh, shoot.
Yeah.
Well, we have it. Guys. You got to know that we have it. Oral semaglutide.
You guys look up Rybelsus. We can't talk about it on this one.
Back in the day, when I was coming through school, it was pre-semaglutide days. And so the big one everybody liked was Victoza because we had leader trial and we didn't have the rewind, right? We didn't have the Trulicity trial come out yet. And then we didn't have semaglutide. And not that Victoza's fallen by the wayside, but it seems like with better data, the once weeklies are more attractive now.
Yeah. So, we'll go back to the rewind trial because it's important to talk about.
Yeah.
But, if you have a patient who, they have type 2 diabetes, especially if they have any kind of cardiovascular risk, other comorbidities like hypertension or something like that, dyslipidemia, maybe they have a elevated BMI. When you're considering injectable therapy in them, then the GLP-1s just make the most sense to start with. It's not that insulin is wrong, but when you have weight loss that needs to be accounted for, also the cardiovascular risk reduction that you get from a GLP-1, it makes sense why the ADA guidelines kind of push us towards a GLP-1 as the first injectable that we use. So that would definitely be a good option to kind of go with.
And they do straight up. They say that comparing GLP-1s to insulin, GLP-1s are preferred because of the weight loss benefit versus weight gain with insulin, lack of hypoglycemia. They prefer those first before you go to insulin, if possible.
So Cole mentioned the leader trial, and that's important because when these medications started getting approved, as well as like the SGLT2 inhibitors, the FDA wanted them to do cardiovascular safety testing to make sure that there was no increased risk of cardiovascular disease with these medications.
Because the older medications probably did have some risk, insulins or sulfonylureas, there's some concern for risk, and it's because what do diabetes patients frequently die of is cardiovascular events. So they want to make sure that all these drugs are not only safe but possibly beneficial, right?
Mm-hmm. And so all of these medications that are in both of those classes, the GLP-1s and the SGLT2s, have undergone these cardiovascular testing, and basically patients who are at risk for cardiovascular disease or maybe have had a secondary prevention patients. The studies have all been kind of slightly different, but basically what they're looking for is hopefully no difference from placebo when it comes to risk, but they were surprisingly surprised.
Yeah.
That's how you say that, with Victoza, because in the leader trial, which is their Victoza's cardiovascular study, the leader trial showed that you actually had some cardiovascular risk reduction with Victoza. And that was all the rage when I was finishing up farm school, because people were like...
And that was all the rage when I was starting farm school.
People were freaking out. They were like, oh my gosh, we have something that can lower cardiovascular risk. Victoza's the end-all be-all. So that's what I was taught, just like Cole was saying.
Once daily Victoza, and even with the once weekly options, we're like, no, we want to convince them to do once daily because we have better data now.
And
but that's old data now.
It's
still good. It's still good.
I definitely do still use some Victoza for sure, especially for our patients that don't have insurance, because we have some programs they can get Victoza for really cheap.
Yeah.
But as far as other, medications in this class that have also done cardiovascular studies, the Ozempic study was SUSTAIN 6, and that also showed that patients could have some cardiovascular risk reduction if you look at the primary composite. It's the way it was set up kind of makes it a little bit hard because it was really a non-inferiority trial. The primary composite was the only superiority piece of it. But there are some other larger follow-up studies planned and things like that. And it was one of the shorter studies, but at least, we know that it's got a good chance of having some cardiovascular risk reduction. And then some of the other studies, like, for example, Excel trial with exenatide ER, no risk reduction compared to placebo. So,
right. But non-inferior, which to them was like, that's why we did this trial, right? To make sure it was non-inferior. So they're all happy for half a second, and then like, oh shoot.
So now we're inferior to A1c lowering, and we don't have cardiovascular. That's a hard pill to swallow.
Yeah, but they were kind of forced.
No pun intended.
They were kind of forced to do these studies. And if you look at the population, I mean, Excel had a lot. It was 14,000 patients versus some of the others were much smaller. Like SUSTAIN 6 was like just under 3,000 patients.
Yeah.
Not saying that a negative or positive for either, but I wonder what would have happened if it was more patients. Who knows?
Yeah, for sure. The Alexa trial was the lixisenatide, and most of you are probably like, I don't really think I've seen much Adlixin. And that's because it also did not have any cardiovascular risk reduction, and it was also inferior with A1c lowering as well. So
you might see it in a new-ish combination injectable, but then there's another one that's better than that either way. So you probably shouldn't see this one too much.
Albiglutide, our friend Tanzium, that's been removed off the market, actually had a decrease in cardiovascular events, but those were released after the drug had been off the market, so that was odd and kind of awkward. It was driven mostly by a decrease in MI, but that was called the Harmony Outcomes trial. And then my personal favorite, the old Rewind trial with Trulicity. So this study I like, because it was done over around 5-year time frame, so it was one of the longer cardiovascular data studies, and it also included the biggest majority. I think it was around 70% of patients, and this were either low risk primary prevention patients, whereas the other ones, the patients were at much higher risk for cardiovascular disease or had a past history of cardiovascular disease,
which is similar to a lot of the benefit we even see with SGLT2s. Most of it is primarily secondary prevention, which is much easier to see cardiovascular risk reduction with secondary prevention. Primary with any medication is extremely difficult to see.
So I definitely am a big fan of the Rewind trial, just because it did show that the cardiovascular risk reduction seems to be very strong with Trulicity.
I even remember being a student we had a Trulicity rep that worked at a clinic, not worked, but was at this clinic a lot that I was working at. And I remember, being annoyed by him because he's trying to push Trulicity. And I'm like, no, we need Victoza because there was no Rewind data yet. It's just funny how things change. And Rewind had a good amount of patients, about 10,000. Mm-hmm. It's very solid.
Absolutely. The other kind of thing to consider is, if you have a patient, who has ASCVD risk, they have diabetes that's uncontrolled, and maybe we have started them on metformin or we're about to start them for the first time on metformin. If we are going to add a GLP-1 to that, kind of right off the bat, or if they've been on metformin and we need to go and add a second agent, then, really it's not like there's anything wrong with starting them on any of the, I mean, there's obviously any of them are better than nothing, but my personal thought process on the matter is with Trulicity, I like the ease of the device itself. I know for a lot of my patients that I work with that are elderly, that pen device is definitely pretty genius. And, the Ozempic is also very easy to use, but the titration is a little bit harder. Plus you have to do the 0.25 milligrams for the 4 weeks, which is kind of sub-therapeutic in a lot of cases, whereas the 0.75 milligrams of the Trulicity for 4 weeks is therapeutic. And I get a good bit of A1c lowering with even that first dose, so that after they finish that first box, you just give them the refill with the second dose and keep going from there. With Ozempic, it gets a little bit more difficult to titrate up, and you have to make sure that the refills are on the 1 milligram box and not the initial starting pack, or that can mess up insurance thing. So that's the only thing I'm a little bit concerned about the Ozempic with my patients, but I definitely have started patients on it for sure. And if I need weight loss for a patient, Ozempic all day.
Right.
Nothing's going to beat out that from a weight loss standpoint.
So really, we have three very solid options: Victoza, Ozempic, Trulicity. Victoza being the once daily, and some people don't like a once weekly injection.
Yeah, some people say they forget if it's once a week.
So if they're already doing their insulin, maybe they can do their Victoza at the same time, and that's helpful for them.
Absolutely.
But Mike mentioned the pen devices. If time, I'll talk about it in a little more detail later. But it is good to make sure with any of these devices that you start with, to ensure there's a good understanding of how to inject them. If only because if the patient accidentally misfires and you have to get another one, it's kind of a pain, and they'll probably go, a week without missing their dose because you might have to get an approval from insurance or get the company to send them a new one, something like that. So just make sure there's good understanding, and to make sure that they're actually getting the dose and it's being administered appropriately. They all have their little nuances about how to use them, but in general, they're all sub-Q. They can be done in the stomach, the buttock, the top of the thigh, the top of the arm, and the tricep area. But yeah, it's good to, I'll go into more detail if we have time, but ensuring proper understanding is important.
So the other thing that is not really thought about too much, I feel like, is what kind of dose adjustments. So with exenatide, the original Byetta, if a patient's creatinine clearance is less than 30, we do have to avoid that particular medication. The exenatide ER by Durion has renal dose adjustments as well. I believe that one's actually 45. I'm double checking myself since I'm saying this into a recording. Yeah, so less than 30, not recommended, and with immediate release, and it's less than 45 mils per minute with EGFR for by Durion, the extended release version. So I don't know the last time that if I saw someone on Bydureon, I'd have to think about remembering to check their EGFR, because a lot of times we don't think about that in these with these agents.
We were dispensing the Bydureon B-Size probably every other day or so, so even a fair amount. And I'm sure that people don't really consider that much because you don't usually have to think about kidneys too much with the GLP-1s. Yeah.
So for those two, just kind of be aware. But the Trulicity, the Ozempic, the Victoza, you're all good. No renal dose adjustments, which is a very I like this chart that Pearls has because it lays all that out perfectly, as well as the titration of each one. And it's one of the charts that's included in the downloads. You can kind of have it all laid out in front of you in case you forget the titration strategies.
Yeah.
The other thing I want to make sure we mention too, since we're on GLP-1s, and I see this every once in a while, is you'll have a patient who was on oral therapy first. So let's say they were on metformin and then Januvia, one of our DPP-4 inhibitors. And then when they are become a candidate, for a injectable, just in my opinion, they would have been a candidate already. But let's say now you're considering them for a GLP-1, make sure you stop the DPP-4 inhibitor. You're not really getting any additional benefit from that. If you think about the pathway, the reason we give a DPP-4 inhibitor is because that's there to block that enzyme that breaks down our natural GLP-1. And so if we are giving the inhibitor of that enzyme along with a synthetic GLP-1 that is made and synthesized to basically reduce the effects of DPP-4 to begin with, giving an inhibitor of our DPP-4 doesn't really do much good other than maybe cause more constipation and nausea. So make sure you stop that DPP-4 inhibitor and, let's just go with the GLP-1s. We don't need both.
Yeah, for sure.
The other thing that I'll mention too, just briefly, is the A1c lowering abilities of GLP-1. Depending on which resource you're looking at, a lot of times they'll say somewhere in the range of 1% to 2% drop in A1c. I'm not a huge fan of describing A1c drops like that for the sole purpose of, those were the studies, in the studies we saw those kind of drops in A1c. If you have a program that's a diabetes education program, for example, at my clinic, where if somebody gets enrolled in our diabetes education program, they go through me, they go through the dietitian, they spend time with other healthcare professionals, and it's a completely encompasses all the different aspects of their education to deal with, all aspects of their diabetes. I get huge drops in A1c from like Trulicity, for example, or Ozempic. I mean, I've had patients go from the teens down to like an A1c of low sixes to where we were stopping the GLP-1 after that, just because, and that was over the course of like 3 or 4 months. So kind of when you're looking at those types of things where you have this set A1c, I don't want you to get confused and see that and say, oh, well, if the patient's A1c is an 11 now and we had a GLP-1, we're only going to get to a 9. That's if you give them the medication and then kick them out the door. Do some education, get them enrolled in diabetes education or with a dietitian and have them change some of their lifestyle things, you will get tremendous A1c lowering as long as the patient makes those changes.
Right. So, if you hand them the pen and leave them to their own devices, you'll probably get what the 1 to 1.8 or whatever it says. But yeah,
absolutely. So,
and I will say that back to the DPP4s, if you look at like inserts, even Lexicomp will have a disclaimer now that says there's due to lack of added glycemic benefit, don't give with a DPP4 basically.
Absolutely.
Yeah. And we mentioned side effects before, but always good to counsel about nausea, because if a patient starts it, they've got their first dose, they're really nauseous, they might just stop it again. But if you tell them that it's self-limiting and transient, then they're much more likely to continue on it. And diarrhea as well, sadly.
And I can't remember if Cole mentioned this earlier, but if the patient has a history of pancreatitis, then we tend to not start a GLP-1.
Right. So there's not too much monitoring that goes into them, but if their triglycerides are super high, pushing 500, might be a good thing to keep an eye on if they're on one of these. And
diabetic gastroparesis is the other one that I tend to forget about until I'm thinking, I'm looking at a patient's chart, because the patient has gastroparesis from uncontrolled diabetes. The decreasing gastric motility and the gastric emptying that you get with the GLP-1 can make that gastroparesis worse. So be aware of that. You're not supposed to use a GLP-1 in that aspect. Anything else as far as, do we need to touch on that?
The only thing I was going to say is just as far as the most recent ADA guidelines go, they also talk about combination therapy. Like you can start a patient on metformin and then kind of stepwise go to a GLP-1. But they say it's completely reasonable to just go ahead and start them both if you want to. Mm-hmm. They will probably see more benefit. And because the majority of patients are going to have to go to the second one anyway, cardiovascular benefit from a GLP-1 and that sort of thing. So combination therapy with metformin and GLP-1 to start is not a bad thing. Probably a good thing.
And the way I actually word that with patients, because a lot of times I'll have a patient referred to me after they've just been recently diagnosed. Their primary care provider will put them on metformin, and then they come see me like a few days later to do the rest of the education piece or adjust meds. And it's hard to tell someone who went from no medication to now they have diabetes and they're just trying to process all this. So my personal way of kind of referencing it to the patient, one, I kind of get them bought in ahead of time, whether you want to call it motivational interviewing or however you want to do that. I always kind of ask them.
Motivational mic. Go on motivational mic.
Something like that. But I get the patient to bring up the fact that their goal would be to get off medication because 95% of people are going to say that. So most of them, you don't even have to kind of lead them that way. They're going to bring that up, that they want to come off medicine eventually. And so I use that to my advantage, and I basically will tell them, hey, when we look at studies, the more aggressive we are in the beginning, and the better control we get of your blood sugar quickly, the quicker and more likely chance we have to decreasing therapy as we go. So I tell people I'm a little bit more aggressive with how I do things in the beginning, but my thought process always going forward is to reduce those number of medications so that you're not on as many meds in the long term. So I'm like, if you bear with me and just trust me in the beginning, plus you do some of the diet changes and stuff that the dietitian tells you, we'll be able to get you off some of the stuff in most situations. And I feel like that helps a little bit. When you tell them the long-term goal is to get them off of therapy, I think that kind of helps them buy into your point a little bit.
Yeah, for sure. I think the only other thing we didn't mention is we talked about Wegovy, the weight loss semaglutide. There's also liraglutide weight loss, a higher dose, and it's branded as Saxenda, which was kind of the precursor, the first GLP-1 that was just approved for weight loss. And now I think Wegovy will put them out of business.
Well, technically they're the same company.
Yeah, same company.
But that's the way to do it. Put yourself out of business and have the next product that beats you.
Well, that's how Novo Nordisk does it. They're like, yeah, we have a drug, but we're going to make one that beats that other drug.
They're good at GLP-1s. We'll give them that. Them and Lilly. I'm big fans. All right, so let's talk about some insulin.
Let's do it.
So once we kind of have a patient established on a GLP-1, or if maybe a GLP-1 is not appropriate for that patient, or maybe they saw a commercial about pancreatitis and they're like, nope, not using one of those. I only want insulin. Okay, that's cool. We can definitely go that route. So typically speaking, when we are starting a patient who is has type 2 diabetes, we're going to start them on a basal insulin first. We're not going to usually jump to basal and prandial dosing. Now, there are some situations where maybe we would do like an MPH insulin in some cases to start, or some people I've seen start like 70-30. It's much easier to get control of their sugar if you start a basal insulin first, as long as they can afford it and have access to the medication itself. So there are definitely a few options available as far as the long-acting insulin. So we have like insulin glargine, which is our Lantus. We also have the term follow-ons, which is the Basaglar and the Semglee. And then we have our, because we can't call them biosimilars in the U.S. That's like a different definition. So it's called follow-ons, I think is the correct terminology, if I remember correctly.
And there's also Trulicity, which isn't a follow-on, but
no, it's a brand new insulin.
More concentrated.
You mean Toujeo?
I mean Toujeo, yeah. Concentrated
That's the
version.
U300 insulin glargine. Yep. We also have insulin degludec, which is the Tresiba, and then we have the insulin Detamir, which is Levomir. Now, I will say with Levomir, all of these are considered long-acting, and in fact, dulaglutide is really long-acting, and the duration...
Ultra, as they say.
Yeah, ultra long-acting. The duration can last up to 42 hours, really, so that one is got a very long duration of action. The glargines are usually going to be around 24 hours. Now, with Levomir, depending on the person, I usually kind of round it to or average it to around 18 hours. So you'll see Levomir's dose split sometimes. But I'm not as big of a fan of Levomir just because I feel like it's harder to get more well-rounded coverage with Levomir compared to the other ones.
Right. It seems to act more like a peaks and valleys type of insulin versus the glargine and the degludec, which are very stable and remain the same throughout. And there actually has been one small study that looked at degludec versus glargine. And for the most part, they were very similar, but they actually did say that degludec had lower risk of nocturnal hypoglycemia, mainly because of how long-acting it was.
Well, and that was the big concern with Trulicity is it going to be like insulin stacking associated with it? And so they were actually thinking that it was going to cause more hypoglycemia or a higher risk for that. But unfortunately, not unfortunately for the other guys,
Right.
They did not
It's
see
actually a
that
little better.
in the study. Yeah, it's actually better, and I've seen that myself too with my patients. When they switch to Degludec, I've had less instances of hypoglycemia and whatnot. So
Yeah.
it is definitely an effective option.
And I did want to say one thing about insulins in general before we get into the rest of them, but a lot of times, Mike mentioned people might want to do insulin instead of a GLP-1. In a lot of cases, people really don't want to do insulin because they've seen a family member who's been on insulin, or they associate it with, poor outcomes, or like the end of the disease, or people who were, have had diabetes for a really long time. So they have a bad association with insulin. And so you might ask them, you might say, okay, so how can we motivate you? Like what would motivate you within like this disease state and diabetes, and what motivates you to get your A1c down and lose weight? And a lot of them might say, I don't want to go on insulin. And so it's really tempting to just tack onto that, and they're motivated by that. So okay, let's do this. We don't want to go on insulin. But it is important to early on kind of set expectations and say, well, insulin it's not necessarily, it doesn't mean you've done anything wrong. It's not a punishment. Like we shouldn't threaten them with, you gotta lose some weight, or you're going to go on insulin or something like that. You want to promote a positive attitude. Say that we have options that we want to use before that, but there are times when the patients just have to be on insulin, and that's what they're going to need to be on. So we don't want to vilify it early on. Otherwise, we'll probably have poor outcomes or poor adherence or whatever later on.
And, I think also too, it's important to kind of address the fact that when patients have loved ones that they've saw kind of have bad outcomes with insulin, the fact that a lot of times it's because they've waited so long to actually get on insulin,
Right.
that that's really the reason. And I've actually explained that to people. The reason why sometimes it looks like insulin is the culprit is because we've waited so long trying all these other things that aren't as effective, when we could have gotten control of the blood sugar early on anyway, and then the patient may have actually had less kidney disease and other things that can happen as a consequence of long-term uncontrolled diabetes.
Right. But like we said, there are negatives about insulin with weight gain and more hypoglycemia and that sort of thing. But overall, it can definitely get control of the sugar because you can titrate it to whatever amount you need it to go to. But injection technique is definitely important with this as well. It's interesting that this is mentioned in the guidelines, but for a leaner, kind of skinnier person, it's mainly with type 1, but with a leaner, skinnier person, if you're accidentally injecting too far into the muscle or using the wrong needle size or something like that, you can get an increased risk for hypoglycemia, because in the muscle it doesn't really absorb as dependably. It's kind of more peaks and valleys sort of thing, even for the long-acting insulins. So injection technique and making sure people are using the appropriate size needles can be important to help prevent those sorts of things. And
I mean, as a kind of generalization, most people have a little bit more adipose tissue on their stomachs compared to their legs or the back of their arms.
Right.
And so that's why, you can inject them in those other alternative sites, but I am definitely someone that encourages patients to use the abdomen if possible. So what about starting dose for basal insulin?
Yeah, so there's various ways that you can come up with something very easy to start with and then titrate up. The guidelines specifically mention 0.1 to 0.2 milligram or units per kilogram per day is a reasonable place to start. Some people, if it's Lantus, just start with 10 units, but there's other calculations you can do as well, right?
Yeah, one other one you can do that's pretty common is a fasting blood glucose. You take the patient's average fasting blood glucose minus 50, and then divide that total by 10, and that equals the number of units.
That's a lot of math for me. I like the 0.1 to 0.2 units.
Well, I like the 10 units and then
10 units and titrate up.
So I'm a big believer in that one. If the patient is willing to check their blood sugar, at home and check their fastings, because what I'll do is usually I'll go up a little bit. I'll do the math to see what their starting dose would be based on their weight, and then I take that and average it with 10, and somewhere in the middle is where I personally pick.
Right. And then, I'm sure that their motivation or how reliable they are will determine if they can self-titrate. Right?
Absolutely.
If you feel like they can check their sugars regularly enough to self-titrate 2 to 3 units, depending on how high their sugar is, or if you're going to have to titrate it yourself and follow up with them closely.
And when Cole says self-titrate, what we mean by that is basically they titrate themselves up 1 to 3 units, like you said, every, usually I personally do every 3 days. And so if their their blood sugar, rather, the fasting blood glucose in the morning is not in that 80 to 130 range, for 3 days in a row, it's above that, then I have them add 1 to 3 units, depending on how high their A1C is to start. And then they do that for 3 days. And then if that's not enough, they add the 1 to 3 units that I told them ahead of time after another 3 days. And they just basically slowly work their way up until we can find the dose that's perfect for them, as opposed to do 20 units, I'll see you back in a month. You come back, their A1C is still high. You go, okay, now do 30 units. It makes it a little bit more specific to that patient, and lets them kind of have control over it as well. Now, I don't do that with every patient by any means. I definitely I'll call patients over the phone and just adjust it based on their numbers myself. But there's definitely patients that are more than comfortable with doing it that way.
And it sounds, somewhat confusing versus just take 1 tablet once daily or whatever, but it's really just one line on the pen. They see that if it's still above this 180 number or whatever it's going to be, just tick it up a couple extra.
Yeah, and I tell people, that's your new dose at that point. Once you see that number coming down, make sure that because I've had some patients that'll go up, and then once they get to that number, then they go back down to whatever the box said to do, and then they're like, oh, my sugar's not controlled again.
Right.
So
now we can get you a new prescription with the new dose when it's time. But yeah.
So that's the basal insulin, and I'm a big believer in using basal insulin to control the fasting, and then the GLP-1s to control the postprandial. The kind of prandial insulin is something I try to save for last line in most patients. If the basal insulin is not an option, for whether it's cost or whatever the case may be, there's also the option of doing a bedtime dose of NPH, which is going to last around 12 hours or so. You could also go to a twice a day NPH if you wanted to. And now as far as the cost goes, and this actually applies for the GLP-1s as well, there are so many patient assistance programs out there. It's kind of ridiculous if you look. Lilly, Novo Nordisk, they all have those companies, or they all have programs that if a patient doesn't have insurance, or they're low income, or they've lost their job, or whatever, they will get you the medication for free. Some of those programs last an entire year. They have copay assistance cards if they do have insurance. There's lots of different ways that we can get them on these medications.
And say the insurance, so there's a couple ways, right? So say they have insurance, but the insurance won't cover it. All you have to have is maybe a couple of, you try an appeal. You appeal it, you get a denial. So you have a PA denial and appeal denial, and you submit that to the patient assistance program. They call the patient, do some income verification, bada bang, bada boom. They've got free drug for a year.
Yep. I think that's I hear price is the number one thing that people say against these GLP-1s, and I really think it's because a lot of people don't realize how many options there are for people.
And it takes effort. I mean, it takes some time. So leverage your support staff. You definitely can't do it all on your own. Or if you have a clinical pharmacist, that's a great job for them.
I was going to say, if you are the clinical support staff.
If you are the clinical pharmacist, you should do this. But if you're a provider, then leverage your support staff, because you're seeing 30 patients in a day. It's hard to.
Oh,
you're not going to be able to write an appeal. It takes 45 minutes or whatever.
Right.
So, yeah.
So that's our basal insulin. And then, like I said, we could potentially use NPH at this point. But if the patient is on basal insulin and their A1C is still elevated, they're on a GLP-1, or if they're not a candidate for a GLP-1 and their A1C is still up there, then we got to decide what we're going to do with prandial insulin.
Mm-hmm.
So one of the things that I kind of get a little alarmed with when I see when someone starts prandial insulin and they just jump right to 3 times a day dosing with someone who has type 2 diabetes. That can definitely lead to an increased risk of hypoglycemia, big time. So, one of the things that I recommend is basically starting, and not just me, this is the ADA too. I shouldn't even say, that sounded stupid. One of the things I recommend when I'm talking to my providers is what I'm actually getting at, not me writing the ADA guidelines. But
maybe they should ask us next time.
I don't think they want our help. we can put it out there. I think we'll get rejected. But
it would be much shorter.
Oh yeah.
You know that executive summary?
Too long. Too long.
Too
Way too long. It's got to be 1 page max. But, the prandial insulin, when we add that on, it should be one dose to start with the largest meal, or at least with the meal that has the greatest postprandial glucose excursion is the terminology the ADA uses. And so that's going to be a way of kind of figuring out where we need to go from there, because then you can add on the second and third meals. But, it's something that we don't need to jump right to 3 times a day, because a patient doing 4 injections a day who doesn't necessarily have to is going to be very hard to make sure that they're being adherent and all that.
And starting aggressive, like we talked about earlier with metformin and GLP-1s, is different than starting aggressively with insulin, because they are much lower risk for hypoglycemia. Insulin's much higher risk for hypoglycemia. So better to, to a reasonable extent, start low and go a little slower.
Yeah. And there's a few different ways you can initiate it. Some people will say to do like 4 units to start with that largest meal and then go up from there. Other people will say to do 10% of the basal insulin dose. I would be more of a 4-unit kind of guy, just to play it safe. I always kind of with insulin.
Easier math.
Air on the I'm better. 4. It's problem solved.
Just do 4.
The 10%. What? And so I always side on the. Or err on the side of caution when it comes to insulins. I go less and then just am quick to titrate versus go big or go home on the first dose.
Right.
But that's, and then from there you can titrate 1 to 2 units or 10 to 15% twice weekly is what the ADA recommends, and then kind of go from there.
And as far as the basal insulin options, we have Lispro, which is Humalog.
Prandial insulin options.
Prandial insulin options. We have Lispro, which is Humalog, Aspart, which is Novolog, Glulicine, which is Apidra, and then Afrezza, which insulin regular. That's the inhaled insulin, right?
Yeah, can't remember the last time I've seen that.
I've never seen it.
Yeah,
but it exists.
Inhaled insulin
is a nice little trivia question.
Yeah,
can you inhale insulin?
Sure.
They're
also working on oral insulin, but we'll cover that another time.
Yeah.
It's in stage.
Well, Mike, this is the injectable episode.
Yeah, sorry.
Can't talk about that.
Listen, you were a bad influence with your semaglutide talk.
With my Rybelsus
talk. So you mentioned, and then also there's some follow-ons as well. So I don't know if did you mention Admelog?
No.
So that's another version of insulin Lispro. That's the same. Just another version of that, basically. We also have Fiasp, which is insulin aspart, but it's actually faster acting. It's got nicotinamide added to it, and then sometimes you'll see it listed as being ultra rapid acting. So it can kind of get into your system even quicker than the other rapid acting insulins do. And then we have another Lispro that's a little bit faster acting. That's the Lyumjev, I think is how you pronounce that. And I can never, ever since that came out, I can never pronounce that correctly.
It sounds like, I don't know, a Swedish word or something.
Lyumjev. But that one's considered to be a little bit more faster acting, kind of like the Fiasp. But yeah.
I think I bought that dresser from IKEA. Lyumjev.
Lyumjev?
Yeah.
Did you?
Yeah.
That's interesting. Good to know. But if the patient doesn't have insurance and they're the cost of it is the biggest issue, we also have our regular insulins as well that are shorter acting, so they're not going to have as quick of an onset as the rapid acting insulins, but we have like Novolin R, Humulin R that are going to be options. They're usually a little bit cheaper. They usually take 30 to 60 minutes to really get in your system versus the rapid acting is about 15. So maybe the timing's a little bit more important there. But like we said earlier, there's so many different patient assistance programs. It's fairly easy to get somebody on one of the rapid acting brand name medications versus making them use a vial of Novolin R still.
Yep. Stacking can be an issue with these, which is like injecting maybe too often, which patients might do if they are concerned about having side effects from hyperglycemia or something like that. So emphasizing that sticking with the appropriate dosing regimen, because if they're injecting too early, the insulin can stack. They have higher levels than they should, increased risk for hypoglycemia. I think the insulin regular is a little higher risk for that as well. And then what if a patient they're injecting at night or their numbers are regular at night, but they're waking up in the morning and their glucose is like skyrocketed? Why would that be? So,
and this comes up. I've seen this multiple times, and even patients who they're checking at one point during the day and they're their numbers look good, but then their A1C just does not reflect that. But a lot of times, the big thing to kind of be aware of is when they're on especially multiple doses of insulin is, are they having hypoglycemic events? Because a lot of patients, when they become hypoglycemic, they are not following the rule of 15s where 15 grams of sugar, wait 15 minutes. People are like, I feel horrible. I'm about to eat some
Where's the
freaking sugar.
cupcakes?
Give me, I remember I had one guy that I've seen when I was working with the city of Charleston, doing consult stuff for diabetes education. And he told me, I asked him what he does when he has a low, because he's having lows all the time. He goes, oh man, I keep a king size Snickers by my bed and like one of those larger bottles of Coca-Cola, and he goes, I eat that thing so fast, and then I down the Coke he's like, I feel better so quick. And I said, yeah, how your sugars look in the morning? He goes, oh, they're through the moon. So it's like, yep. So let's go ahead and adjust your insulin dose at bedtime, or at least with your meal, your dinner dose of insulin, because we want to make sure that we are not causing hypoglycemia, especially during the night, because they're going to get up and treat it themselves, and that can throw off their entire average for the day.
So it can be from them treating it themselves. And there's also something called the Samoji Effect, which is where when they're having lows, maybe they're unaware of it, they're still asleep, but their body recognizes that and releases a large amount of glucose during the night. And so when they wake up, they're having hyperglycemic excursions, as they would say. So
absolutely.
Samoji Effect.
And then, as far as the prandial insulins go, if you can use one of the rapid acting, those are definitely probably ideal. And we talked about the onset of action, but in my opinion, the risk of having someone dose a insulin, like if it's a regular insulin, 30 to 60 minutes before the meal, something could come up and they could be interrupted and not have that meal. Right. The rapid acting insulin, it's really, I tell people to start, they inject it right as they start their meal, but technically 15 minutes or less, that's going to be the way to do it, so that you can ensure that the patient's going to actually sit down and eat that meal. And I usually, like I said, tell people right as you start, that way I know for a fact there's nothing going to be interrupting them, and their risk of hypoglycemia is not going to be as great. Right.
Another benefit of GLP-1s, because like Mike said, it's glucose-dependent insulin release. No glucose, no insulin release.
Yeah. One other thing with prandial insulin that I want to make sure we mention that drives me insane, literally, is certain sliding scales. So if you're going to put someone on a slide, and you put them on a slide that sounds something like this, which I've seen multiple times from like EDs and whatnot. If your insulin is 150 or less, then use 0 units. If your blood glucose is 150 or less, 0 units. If it's 200 to 1 or 150 to 200, use 2 units. If it's 200 to 250, use 4 units, and they go up. We want a patient's blood sugar to be less than 130, 180 to 130 really before their meal, if possible. That means that they're controlled. That means that the last meal that they ate, the medication that did its job, or they followed their diet or whatever, we don't want to have to correct necessarily. The slide is there to not only adjust for the amount of carbs that they're about to eat, but also to fix and correct their excursion that they've already been on. So if you're 150 and then you don't use any insulin with that meal, that's how you get huge postprandial spikes. So the next meal, it's going to be through the roof, and then you have to use your slide, right, and then go from there. It throws the whole thing off. Have a set number of units that you're going to use with the meal. That's going to cover the actual meal, and then you can use the slide to then adjust and kind of account for, correct, however you want to say it, for the blood sugar excursion that they're having before the meal as well. Right. So that's where it would be like 4 units with every meal, or with dinner or whatever. And if your blood sugar is 150 to 200, add 2 units to that. So they would do 6 total instead of just 4. That way you've corrected the blood sugar that's elevated, and are also accounting for the carbohydrates that they're about to eat.
And I'm sure the thought process, like for example with the 150 or less, don't use anything, is they don't want people to have hypoglycemia. But if they're about to eat, they're not going to have hypoglycemia.
Exactly. And if they're going to eat and there's any kind of carbs, especially if they're having literally a salad with nothing on it, maybe then we would be a little bit more cautious. Not that many people go that route.
Right.
And then we can just use a GLP-1, so we don't have to worry about that.
Don't even have to worry.
Yeah, because then
So yes, this is what we're talking when you get to the point of needing insulin.
Yeah. So there it is. What else, man? Anything in particular that we've left off? Or
That's some good stuff. The only couple things I wanted to mention is that they do have. So we've been talking about GLP-1s and insulins the whole time.
We've also both said a couple things I want to mention. We've mentioned 100 things, and we've prefaced it each time with, I want to mention a couple things.
Okay, here's literally 3 more things I can think of.
Okay.
Exactly 3. They do have combined them now, right? So there's a combination. One of them is called Zoltify. I actually did my grand rounds on this. But it's insulin degludec, so Tresiba mixed with liraglutide, which is Victoza, which both are pretty solid drugs. Victoza's once daily, so you can give it once a day with the insulin. So this would be covering your basal and then covering your GLP-1. So interesting, not a bad option. You don't see it much, but to decrease an injection burden, not a bad option. There's another one called Celiqua, which is insulin glargine, which is Lantus, which is fine, but then also with lixisenatide, Adlixin. So definitely, if I was going to use one of those combos, I'd prefer Zoltify, just because we don't prefer lixisenatide as the GLP-1 of choice, but Victoza is a fine option. But of course, you're not going to see one of these combos with one of the once weekly GLP-1s, because at this point, at least, we don't have a once weekly insulin, though that would be nice.
Yep. I'm sure it's coming.
But yeah, those are 2 other newer options. I've actually seen Celiqua quite a few times, but I have not. I did have one patient on Zoltify as well, but not a whole lot. Definitely see just the plain GLP-1s or plain insulin a lot more than this. But later on, in our careers, we might see this more often, just for ease of injection.
In our long careers.
We've got a while to go.
Well, some of us less than others. Cole is 10 years younger than me.
Negative.
Something like that.
Something like that.
But that's good stuff. Anything else before we wrap it up?
I think we covered every injectable there is.
And
diabetes.
someone's screaming at home going, no, you didn't.
We got some. Wegovy was like this month.
We didn't really
2 weeks ago
cover the 70-30. So
no, we didn't.
I will say just one caveat to that is if you are having someone on a 70-30, make sure that they take it before breakfast and before dinner so they can get the benefits of the prandial component of that combination. Of so many people, I would say 8 out of 10 people that I ask how they're taking their 70-30, they take it in the morning with breakfast like they're supposed to, and the next one is taken at night before bed.
Right.
Take it with before dinner.
There's one intermediate and one rapid.
Yeah.
Yeah, one rapid.
There's a few different versions, but like the Novolog 70-30, for example, is the rapid. So get the benefit of the rapid with taking it with the meal.
Exactly.
So, yeah. Also, to make sure, like we said at the beginning, check out Pearls.com. So that's pyrls.com/CoreConsultRx. Put in your email address, and they will send you a 10-page diabetes pharmacotherapy chart bundle that is yours to keep, regardless of whether you ever use the app. The founder of it, Dr. David Borkowski, is a good guide. He's really got a cool vision for how this is going to work out. So I'm a fan myself, and I'm glad he's decided to partner with us. So make sure you check that out, and give that a shot. See what you think. Worst case scenario, you just unsubscribe from his email. He's will be okay with that, I promise. But just make sure you check out that. Get your free 10-page bundle. That way you can kind of follow along with what we were talking about a little bit better. And then also, if you are a member of freece.com, if you're not a member, you need to correct your path. And then if you are a member already, make sure you go to the link in the show notes and use the code GLUCOSE, all caps, to claim your 1-hour continuing education credit for this episode. And then let us know if you guys are liking these continuing ed accredited episodes, if they're helpful, if you're able to kind of follow along and feel like you're learning from them. I know me personally, I feel like I would do better with this type of format versus a lecture. I'm zoned out 5 minutes into a lecture, to be honest. So, if you guys are liking it, we'd love to hear some feedback. If you have ideas for episode content or anything like that could be accredited, let us know. If you want to email us, our emails will be in the show notes. We also will have, our Instagram and all the other social media platforms are available as well in the show notes, so you can reach out to us there. You can text us directly at 415-943-6116. And then we'll get back to you on any of those as quick as we can. We do tend to get a lot of messages nowadays, so I promise we'll get to you, but if it takes a couple days, I apologize. And then also thank you guys so much for those of you who have subscribed on Patreon. I hope you're liking the lectures on there. And we got a lot more coming in the pipeline for that as well. So I think we're up to around 80, maybe a little bit more than 80 lectures and probably thousands of slide sets for $3 a month. Or subscribe once, download everything, and then blow on out of there. There you go. You get $3 for thousands of slides. It's the deal of the century. But yeah, thank you guys so much for the support, and we will see you guys in the next episode. Have a great night.